Good morning, everyone. We're just going to take a couple minutes to let everyone log in, and then we will get started. Just a couple more minutes and we'll get started. All right, good morning, everyone. Welcome back. Thank you for joining us for another HRG Outbreak Outreach webinar. We're so happy to have you with us this morning as we can continue to navigate through the COVID-19 crisis. HRG just wants to make sure that we're here for you, sharing industry updates, best practices as we continue to navigate. Before we get started, just a couple of housekeeping items. Feel free to ask questions as they come up in the question box inside your control panel. In order to make sure that we honor the amount of time we have allotted today, we are going to be sending out an email that will include a question and answer sheet for any of the questions that you guys have. That's where we'll have those answers for you. After the presentation, if you guys are needing a certificate of attendance or you guys have any additional questions, please just make sure to fill out the survey and we will be sure to answer those that way. This morning, we have HRG's Coding Manager, Troy West, presenting on how to best prepare for the 2021 E&M guideline changes. Troy, go ahead and take it away.
All right, thank you very much. Yes, this is the webinar preparing for 2021 E&M guideline changes. Thank you all for attending, and I hope we can provide information that you find useful and help your practices. My name is Troy West. I am the HIM Coding Manager here at Healthcare Resource Group. I have been working in healthcare and coding for the past 17 years. Just a little caveat before we get into it. I am currently working from home, as many are. I do have a house full of children, dogs, and cats, and I have asked them to be quiet, but they've never listened to me before, so hopefully this will be a first. But I'll do my best to keep the audio clear. And then, like was said, please feel free to ask questions. If there are topics that come up that I could be more concise on or you need some clarifications on, so the HRG coding team can work on those. Starting with an overview of the topic that we'll be discussing today, the revisions from the American Medical Association are mostly focused on CPT 99202 through CPT 99215. So it is for new and established office visits. And the big change that's really coming down is that E&M code selection will be based on either time or medical decision making. That means that the history and the physical exam will no longer play a part in choosing your E&M code. While the history and exam will still be part of the office services when appropriate as determined by the physician. For example, the care team can provide, or the patient can provide their history and have the physician just review it instead of actually having to do it himself and make that part of the documentation. These revisions by the AMA are scheduled to go into effect on January 1st, 2021. Please be aware that because there is time before then that there could be changes to the material presented today. I know there is at least one CPT code they haven't finalized, and CMS is still working on reimbursement rates. So there could still be updates and something to keep an eye out for. One of the reasons that these revisions are coming is to really help physicians get more, both face-to-face and non-face time, focusing in on the patient and less time focusing in on administrative burdens like their documentation to make it easier and improve quality of care. When the AMA set out to make these revisions, they had a few goals in mind, what they were reaching for. The first was to meet CMS's Patients Over Paperwork initiative. This initiative by CMS was started back in 2017, and their goals for it was to increase customer satisfaction, decrease the amount of hours that were needed to meet their compliance rules, and to increase the digital tasks for their customers. The AMA is also, one of their goals was to eliminate the requirements for the physicians to re-record elements of the history and the physical exam. They will still be required to document that they did review those things, but they can now have that information provided by the patient or ancillary staff. The AMA is also looking to simplify the code selection criteria and make them more relevant and intuitive. They're really hoping with the focus on time and medical decision making that it'll be easier for coders to pick the correct levels rather than what they consider the more tedious 1995 and 1997 guidelines. The AMA is also hoping to create consistency across payers by adding detail within the CPT E&M guidelines, just a little less subjectivity so that payer that you're trying to meet their documentation requirements are a little easier to do, and there's a little less wiggle room for them to interpret these guidelines. And also, when they made these revisions, they wanted to do an alignment with the current documentation guidelines that were being received from Medicare so that it matched with the CPT code set. So when you do make these revisions, it would cause minimal disruption to your practices. They really felt that medical decision making, and time already being factors in E&M leveling, this was just a very natural evolution of that process. So starting with the first of the two criteria that you can use for your code selection, which is time. As of that January 1st, time alone will now be usable for determining the level of the E&M for the office visit or outpatient service. There is still a requirement of face-to-face time, but the time total will be all the face-to-face and non-face-to-face time for a date of an encounter added together. It is important to be aware, though, that for other categories of E&M services, they are going to use time differently. So it is important to review the instructions for each category of E&M. Like I said, we're mostly focusing on those office visits today, but it is important to review those guidelines for the other categories as they will use time differently. A really good example of that is the emergency department. Because the services are usually provided on a variable intensity basis, they didn't feel that time was appropriate for reporting ED levels. The physicians are seeing multiple patients across multiple encounters for multiple prolonged times of service, which makes it hard to estimate and be accurate with the time spent, so they aren't using time for ED. Regarding shared or split visits, the time personally spent by the physician or the assessing or that are managing on a data service is going to be summed up for that total time, but be aware that only distinct time should be in that sum of time for those shared or split visits. Any specifically identifiable procedure or service that is identified with a specific CPT code that's performed on the same date of an E&M service may be reported separately. And this is a pretty important caveat that they've added for both the time and the medical decision making. If you are reporting something with a separate E&M service, which you can for, or separate CPT code, which you can for a lot of services, it would not be factored into either the time or the medical decision making. However, it is important to note that if a test is independently interpreted as part of, in order to manage the patient as part of their E&M service, but then you don't separately report it, then that would be considered part of the E&M service and would be included. On this slide, I have a list of the activities that a physician can perform that would be considered included in the total time of the care of the patient to determine that E&M level. We have preparing to see the patient, and they give an example of reviewing tests, obtaining and or reviewing separately obtained histories, performing a medically appropriate examination or an evaluation, counseling and educating the patient, the family, or the caregiver, ordering the medications, ordering the tests, or ordering of procedures, the referring and communicating with other healthcare professionals when you're not separately reporting it, documenting clinical information in the electronic or other health record, and independently interpreting results, again, not separately reported, and then communicating those results to the patient, to the family, or the caregiver, and then also care coordination, and once again, when not separately reported. The other criteria besides time that we're using, obviously, is the medical decision making, and the AMA has broken that down into 3 elements for determining the level. The first element is the number and complexity of the problems the patient is presenting with. An example would be a level 2 would have either one self-limited or very minor problem that they're presenting with, while a level 5 would have one or more chronic illnesses that have severe exacerbation, severe progression, or severe side effects for their treatment. Also, a level 5 would be an acute chronic illness or injury that is either life-threatening or threatening to bodily function. The second element in medical decision-making is the amount of the complexity of data that has to be reviewed. This would include medical records, test, and any other info that has to be obtained, has to be ordered, has to be reviewed and analyzed from the encounter. The AMA gives examples. A level 2 would either be minimal or no data review needed. And then for a level 5, they actually break it down into 3 categories. And to meet a level 5, you would have to have 2 of the 3 categories met. Their categories are reviewing or ordering tests, the independent interpretation of tests, and the discussion of management of test interpretations. So you'd have to have 2 of those to meet a level 5. And then the last element for the medical decision making is the risk of the complications, of the morbidity, of the mortality of patient management decisions that are at the visit and that are associated with the patient's presenting problems of the diagnostic procedure and or the treatments. It should be known that you can include possible management options that are selected, and also those that are considered but not selected, but that you did shared medical decision making with the patient or their family. Again, the AMA, for their examples, lists level 2 as something with just minimal risk in the decision making, whereas a level 5 would be something with high risk, such as elective major surgery, emergency surgery, or hospitalization. Again, just like with time, when reporting a separate CPT code that includes the interpretation in the report, it is not included in the level of decision when you're using medical decision making. So if you're reporting a separate CPT separate, it is not considered part of that E&M and determining the E&M level. The examples that I listed were provided by the AMA. They have a table that some of you may have, but I have provided a link for it on the last slide of this presentation, and it will be shared with the materials as well. Dealing with prolonged services, there have been some changes for codes 99354 and 99357. These are for prolonged services that are face-to-face when not done with an office visit or outpatient service. Codes 99358 and 99359 are for non-face-to-face time in the outpatient inpatient observation setting, nor additional unit floor time in the hospital or nursing facility setting. Those used to include the E&M in the past, and that has been removed. However, there is a new code, and the code has not been finalized, so right now they're using as a reference code 99XXX, but they are creating this code for face-to-face or non-face-to-face time past the physician after an E&M office visit. This would be used with CPTs 99205 or 99215. And one thing I wanted to note in the bottom of the slide where the description of the CPT is listed, in their brackets they list beyond the total time of the primary procedure, which has been selected using total time. So those level 5s that you would bill this with would have to be chosen using time. And then this CPT is used for every additional 15 minutes. CMS is still finalizing their reimbursement levels for these changes. Originally, they had proposed a more dramatic change. They were looking to consolidate the payment rate of level 2s, level 3s, and level 4s into one rate. So you would have one rate for new codes and one rate for established codes for these levels, and then there would be a rate for level 1s and rate for level 5s. They have backtracked on this and are currently proposing to stick to a 5-tier payment system for established patients and then go to a 4-tier system for new patients. Also, the current proposal that I've seen for the new CPT code that hasn't been decided yet, they're proposing to reimburse that at $17, which is, again, for every 15 minutes. The AMA has prepared tips to prepare your practice for these changes. With such big changes coming down the line, they provided these, and I'd like to go over them. There are some definitely helpful things that you can pull out of this. The first is to identify a project lead. This transition is going to require staff education. It's going to require review of your internal policies and financial tracking. The best way to get this facilitated and go through these steps is with someone in charge of the task and driving it forward. They also recommend scheduling team preparation time, taking time to walk through these changes with your physicians, with your clinical staff, with administrative personnel, scheduling time to go over these changes so that they can understand them and ask questions and be ready for these changes when they come about. They also recommend updating your practice protocols. Protocols will need to be updated with these new guidelines. The AMA's recommendation is to leverage your practice's established coding resources and expertise early in this process. They do also recommend considering coding support just because of how big these changes can be and how big an impact they could have on your practice. It might be worth looking into. A very important one is to be aware of medical malpractice liability. We are seeing with this documentation that it's going to be more loose and more flexible, which will help physicians, but they do still need to be careful that they are documenting that the work that they've done and they're protecting themselves from malpractice suits. And very much in line with that is the next one, to guard against fraud and abuse law infractions. Again, there is a lot more flexibility in your documentation, but things like the False Claims Act, federal and state laws are all in effect, and it's important to focus on documenting what's appropriate and guarding against overpayment. It's a good time to update your compliance plan as your protocols will be changing, making sure that your compliance plan is staying consistent with those changes. And so that's another recommendation. They also said to check with your electronic health record vendor. The AMA is reaching out across the country to EHR vendors to get them up to speed, to get them ready, but it's still a good idea to make a call to your vendor, see what their schedule is, make sure that they're going to be ready so you can be ready on January 1st. It's also important to assess the financial impact. What kind of levels are you going to be seeing versus what you had been seeing in the past? Were history and exams an important part of your level criteria, or were they more driven by medical decision making? Is time going to play a factor that you can use that more often? You might be having higher levels, you might be having lower levels, and that's a good thing to get an idea of so you can understand this. And also paying attention to the reimbursement rates that CMS and other payers are deciding for these changes as they come in. This can really help with unanticipated financial impact for your practice. It's also important to understand that additional payers or employers or medical liability coverage might have different coverage requirements. CMS has been very much in line with AMA's new revisions, and so that's been a really blessing, but other places we send our claims to might not. They might have additional documentation requirements, and you need to make sure your physicians are aware of that to meet both those requirements and the guidelines of the AMA. On my last slide here, I do have two links. The first is to the AMA's PDF where they made most of these decisions. You can find most of this general information that I've presented there. I wanted to make sure that you guys had that as a reference, as a resource for your practices. And then the second link is that table I mentioned earlier with the medical decision making by the AMA. It's a really good resource, and I do not believe it will be included in CPT books. So good way to get a hold of that. With that, I encourage you guys to send in your questions if you have additional ones so that the HRG coding team and QA department can probably together get those answered and provide the resources you're needing, help the way we can. And I really want to thank Taylor and Molly for helping me put together this webinar, and I will turn it back over to them. Thank you, guys.
Awesome, Troy. Thanks so much. You did a great job. So everyone, as usual, we will be sending out all of the webinar resources later on today. That'll include the slides as well as the recording of today's webinar, so you can share it with your team if they weren't able to make it. As well as we will include a survey. If you guys could go ahead and fill out that survey, we are giving out gift cards for, or a gift card for the winner, excuse me, we're giving out a gift card for people to fill out the survey. So if you can go ahead and do that for us, we'd really appreciate it. Finally, I did want to mention one thing that we've added to the HRG website. That is our COVID-19 questions. We have revenue cycle specialists available to answer any questions you guys might have just in general about how HRG or how best practices can happen, what you can do to navigate the crisis. So feel free to visit our website and ask us any questions. With that, we're going to go ahead and end today, and we will see you guys next week.